Dr. Reddy is a clinical professor and vice chair of clinical affairs in the Department of Obstetrics and Gynecology. She's board certified in OBGYN with clinical expertise in minimally invasive surgery and menopause management. Her practice includes a full range of gynecologic procedures with particular interest in abnormal uterine bleeding, fibroids, endometriosis, and menopausal care. Dr. Reddy is also dedicated to surgical education and actively mentors OBGYN trainees in both clinical and academic settings. And Dr. Reddy will be talking about menopause and hormone replacement therapy. You may see a theme here during the course of the afternoon of topics that are especially important during menopause. Then our other speaker for this last session will be Nancy Stewart. Dr. Stewart is an assistant professor of medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine. She's involved nationally in guideline development, medical education milestone and development, and leadership roles within pulmonary, critical care, and sleep medicine organizations. She has published extensively and has done invited talks on topics such as sleep health in the hospital and sleep disorders and lung disease. Her research focuses on improving sleep health in patients with COPD, and Dr. Stewart will be talking about sleep health. But first, I will turn this over to Dr. Reddy. Thank you very much.
Well, thank you, Dr. Templeton. Thank you for that introduction. I'm gonna, I know the topic is menopause, but I wanted to focus a little bit more on menopause transition, so right before menopause starts, and then also hormone therapy during that time and in menopause. So my disclosures that I have none. I am a Menopause Society certified practitioner, so which can be looked up online. That's how some of our patients find us. And objectives for the talk, again, to understand the physiology of menopause transition, and then we'll talk more about hormone therapy after that in terms of benefits and contraindications, and then about how to transition from contraception to menopause therapy, and then also talk about oral versus transdermal versus vaginal hormone therapy. So there's a lot to cover, so I'm going to try to cover in that 25 minutes. So let's see how that goes. So just for introduction, as you know, menopause is a natural event and is defined clinically by cessation of menses for a year, and is defined by when that final menstrual period occurs and then confirmed about a year later. Normally, it can occur anywhere between 40 to 58 years of age. And then average age of menopause is around 51 to 52 for North America and women, with 90% of women who have gone through menopause by age 54, 55. But this has, of course, with the increasing life expectancy over many last few decades, really, it hasn't been that long that we find women spend much of their life, really about 40 to 50% of their life in menopause. So it's important to understand the changes that happen and how to take care of these women. But the most symptomatic time for women is really during the menopause transition, or sometimes as we all call it, perimenopause. And this is the time many different symptoms can occur, including abnormal uterine bleeding, vasomotor symptoms, increasing PMS symptoms. You have sleep disturbances that occur. There's irritability, mood changes. There's weight changes that occur as our hormonal changes happen in our body. There's definitely cognitive changes, which often in lay terms is called brain fog. You have skin and hair changes as the ratios between testosterone and estrogen is starting to change, and then many more different symptoms. And then when you look at the stages of reproductive cycles for women, there's a classification called STRAW plus 10, which divide a woman's reproductive stages into 10 different stages. But the stages that I'm focusing on is really like early perimenopause, late perimenopause, menopause, and then early postmenopause, and then the late postmenopause. The focus is going to be in that early phases, early peri and late perimenopause, which can which can kind of last for up to 8 to 10 years. And like I said, are very symptomatic at this point. And then what do we do? How do we find out, what are the differences between these early versus late transition? There's many hormonal changes happening. There's unfortunately, lab testing doesn't help in these situations because the labs are fluctuating, as I'm going to demonstrate in a few minutes. But in terms of clinically, what the most common symptom you see is irregular bleeding irregularity. So cycle changes can happen in early transition that look like maybe the cycle is either lengthening or shortening. So your day one to day one of a period can be usually shortened, sometimes also lengthened, but plus or minus 7 days. And then you can have in the late menopause, the same cycle length can also vary, but usually it is evidenced by periods of amenorrhea. So your periods may go away for a month or two and then come back. So that's kind of more of a sign of late transition, a late perimenopause. And then in terms of other symptoms, in early menopause, people may have vasomotor symptoms, hot flashes, night sweats, etc., but they may be mild, they may be transient, they may have 1 month, but not the other month. And then in late menopause transition, you will more likely to have vasomotor symptoms as a main symptom. And then other symptoms you see in early menopause transition would be pronounced PMS type symptoms. So a lot of irritability, mood changes, those kind of things can happen. So those are, as people are, describing these type of symptoms and showing the signs of transition, it may help to know where they are to kind of help them how to guide depending on their goals. In early menopause, you also will note in terms of labs, I'm going to tell you not to do labs for diagnosis, but in terms of, say, they have reproductive needs, this may be the time you may want to test early follicular FSH or anti-Mullerian hormone to kind of determine if they have ovarian reserve or not. So otherwise, we usually don't check too many labs during this time. And the reason why is because hormones during perimenopause are very chaotic. There's no rhyme or reason about what's going to happen. So in premenopause, our hormones do fluctuate, but they have a cycle, they have a pattern, so that's predictable. So the levels are very predictable. Even in that situation, it's hard to check levels at a certain time because they may be high at certain times, low at sometimes. So we usually don't check labs unless there's a specific clinical scenario. In perimenopause, it's extreme chaos. So it may be very much different depending on when you check them, and you don't even know where they are on their cycle, so you don't know exactly when to check them. So for example, if you check the hormones, FSH and estradiol, for example, which is used to kind of find maybe diagnose menopause sometimes, FSH, if you checked it right here, FSH would be high, estrogen would be low, and you would think, oh, they're in menopause, but then a week later you can check and then you would have FSH that's low and estrogen that's high. So it won't help us diagnose. So therefore, a lot of these diagnoses is made clinically and not by lab. So first take-home point for the presentation, laboratory testing for hormone levels is not helpful in majority of the cases. It is important, though, to rule out other causes of the similar symptoms. So if you have fatigue, you have anemia, you can rule out anemia, thyroid dysfunction. If they have, palpitations or other hair loss or things like that, rule out other deficiencies, look for other cardiac causes. If you have dizziness, for example, things like that. So you want to make sure you're looking for other reasons for these symptoms and not assume that it's perimenopause. So there's a fine balance of this, so these symptoms could be because of perimenopause. So you want to rule things out, but then also, and then consider perimenopause, but don't jump to the perimenopause as our first kind of diagnosis is the main ask, I guess, of all of you. And then the other take-home point is that, many people, like I said, present with bleeding irregularities. So, but that doesn't mean that's the only cause. So this is also in the early, late 40s, early 50s are also the time. It's also the time when you have increased risk of uterine cancer. So you want to make sure if you have irregular bleeding, you're also doing some endometrial evaluation, either by ultrasound or biopsy or both. So that's definitely not to be ignored and then assume that it's because of menopause or transition. And then, what do we do about menopause hormone therapy? So the goal for hormone therapy during this time is to take away the highs and lows of the hormone swings. If you put them on a menopause hormone therapy, it's frequently too low to control those highs and lows. It will not suppress that HPO axis that has gone wild during this time. So if you put them on menopause hormone therapy, then it's often will cause increased bleeding. So if they didn't have bleeding, then you may have increased irregular bleeding, and then you will go into this rabbit hole of evaluation of bleeding and all this stuff. So it's very important to kind of understand the goal is really to take away the highs and lows. So it needs to be kind of directed towards suppression of the HPO axis. And then also in this period, remember, people are still ovulating, so you want to make sure you consider the need for contraception. Often the most common medication that I would prescribe during this time, if they don't have any other contraindications, is to do a continuous combination oral contraceptive. It gives them the estrogen and progesterone. It will suppress the HPO axis and then kind of level out the hormones. The other option that you have, that's also one of my favorites, would be to put an IUD, a Mirena IUD, or I'm sorry, a levonorgestrel IUD, and in the uterus. So that does not suppress the HPO axis, but it will basically cause the endometrium to become atrophic and control the bleeding. In that situation, then you can use menopause hormone therapy with estrogen patch, for example, to help with the lows, with you're not suppressing the HPO axis anymore. You're just taking away the lows to help with the symptoms. So that's another option for patients. And then for patients who have contraindications to estrogen, this would be a good population to consider drospirenone oral contraceptive alone if you have an estrogen contraindication. You can also use the drospirenone oral contraceptive, for example, with estradiol patch if you want, because the drospirenone will give you bleeding control and suppress the HPO axis. So those are all kind of the different options, okay? And then remember, I'm gonna probably bring this point over and over. Any patient with the uterus will need progesterone with any type of systemic estrogen. So we wanna make sure we're protecting that uterus because unopposed estrogen can cause endometrial hyperplasia and cancer. Okay. And then, most common question that I get asked often when we're talking about perimenopause hormone therapy, especially with, say, oral contraceptives, for example, is how long should we continue this perimenopause therapy? Because when you're on this therapy, you will not know when they're in menopause because this will mask the entry into menopause. So how long should you continue? The when to transition is really individualized. We had talked about typical age of menopause is around age 51, 52. So a lot of menopause practitioners will continue the hormone therapy and contraception, I'm sorry, until that typical age of menopause and then transition if they're symptomatic after that. So you would stop the pills and then wait a month or two or start, or you can just transition immediately without wait for symptoms. So that's kind of what I usually do is transition at about 52. Now, if they're not in menopause at that time, and then I've switched them to menopause hormone therapy, they will present with some, either bleeding or something like that, then I can kind of readdress that issue. And then during this time, you also want to make sure you're counseling the patient that your hormone levels, because the hormone levels in the birth control pills are much more potent than in the menopause hormone therapy. They may have some hot flashes that transiently appear, but they will disappear within a couple weeks. And then now let's switch to menopause hormone therapy. So we talked about perimenopause, which is more goal-oriented towards HPO axis and taking away highs and lows. But for menopause, their hormone therapy, it's more about symptom control. So let's talk about, I'm going to kind of cover a few different things about hormone therapy, including the benefits, contraindications, and then vaginal therapy, how that's different. Okay, so what are the different categories of hormone therapy? Well, there's estrogen therapy. So for people who give only estrogen, this is given as systemic estrogen for women who have undergone a hysterectomy. Or you can give estrogen therapy that is not systemic, that is given only in the vagina in low doses. Okay, so those are the two different types of estrogen therapy. Estrogen plus progesterone therapy is what you give for any postmenopausal woman who has a uterus. So because the progesterone reduces the risk of endometrial cancer. Which would otherwise be present if you had unopposed estrogen. And then you also less frequently used, but you have a progesterone systemic therapy that can be given. It's off-label for menopause, but we sometimes will use that when women have contraindications to estrogen therapy, but have significant vasomotor symptoms. So those are all the different categories of hormone therapy. When do you give hormone therapy? According to the FDA indications, you can give hormone therapy for vasomotor symptoms. And you have a FDA indication for hormone therapy for prevention of osteoporosis. So remember, this is not to be considered as a treatment for osteoporosis, but it can be given for prevention. And then if you have some sort of a premature hypoestrogenism, like surgical menopause, primary ovarian insufficiency, or hypogonadism, then you would want to that would be also a FDA-approved reason for hormone therapy. And then the last is anything genitourinary syndrome of menopause, which is constellation of symptoms, but a lot of times we clinically kind of consider that as vaginal atrophy, but constellation of symptoms including irritation, itching, urinary frequency, all dyspareunia, they all kind of constitute into this genitourinary syndrome of menopause. So all of these are indications for HT. That doesn't mean this is the only reason you get HT. There's plenty of benefit. There's plenty of evidence that it can help with increasing the quality of life. It can improve your brain health, decreases brain fog. It can decrease the risk of type 2 diabetes, can positively impact lipids depending on the route, how estrogen is given. It also, there's increasing evidence that it helps with some joint pain, arthalgia that happens in menopause, perimenopause, menopause time. It also evidence now that if you give hormone therapy within the 5 years of the final menstrual period, that it could be cardioprotective as well. So there are other reasons to give hormone therapy that's not completely FDA kind of indication, but off-label use of hormone therapy. Other question, we all ask is, is it safe? Can I take it? There was all this hoopla about cancer and hormone therapy. So is it okay to take it? So one of the biggest study that came out that really swung the hormone pendulum all the way to nobody take it was this WHI study that came out in 2002. So quite a long time ago, that looked at it was a well-designed, randomized, blinded study where they had, many people, I think very high N in terms of enrollment and everything. And so well-designed study that looked at equine estrogens, brand name Premarin, with medroxyprogesterone, which is Provera. So Prem-Pro, and then also they had another arm of study that looked at only Premarin. So two arms, and and then both arms had control. So that study, when they looked at estrogen plus Provera arm, they had a small increased risk of breast cancer after about 3 to 5 years of use. So therefore, that arm of the study was stopped early. When they looked at it, they noticed that really when they kind of relooked at that data and reanalyzed and all that, they found out that the control group for that arm had unusually low risk of breast cancer. So accounting for all of the things that they looked at, there was one additional breast cancer per 1,000 women years, with no increase in mortality that was caused by breast cancer. So that was interesting for me. So that is a very small, moderate increased risk of breast cancer, especially if you give conjugated equine estrogen, so which nowadays we almost never give, um, with medroxyprogesterone. And then in that same study, the arm that was looking at only the conjugated equine estrogen showed actually a little bit lower risk of breast cancer in women. So interesting study. And then also nowadays, and then more recent observational studies have shown that micronized progesterone, a brand name Prometrium, in comparison to that Provera they used in that original WHI study, actually showed less impact on breast cancer. So you have to kind of take it with a grain of salt in terms of risk of breast cancer with hormone therapy. And then the other risk of estrogen that we always worry about is VTE, which is also, we need to look at, in terms of what is the risk and what is the risk if you give it oral versus transdermal. But there is definitely risk of VTE with estrogen. So I'm going to kind of address that in another slide. But those are the safety issues to think about. And then, and I kind of mentioned the timing of estrogen. So like there may be cardioprotection if you give it, early in the menopause. So this is evidence. So that kind of occurred in most recent studies. That's what it showed, that there's decreased risk and maybe some cardioprotection if you give it early in the menopause. But before those studies came out, there was this hypothesis that, we have if you just give it early enough, there's no changes in the vasculature of the heart, so the estrogen will actually be protective. And that hypothesis, even when they looked at WHI study, was kind of seen that it is possible. So the absolute risk of coronary heart disease was lower in younger women who were recently postmenopausal women. That's from WHI. And then use of hormone therapy within 10 years of onset of menopause was associated with lower coronary heart disease compared to greater than 10 years. And then also women who were younger in their 50s in the estrogen arm had more favorable all-cause mortality outcome and fewer MIs if they were on estrogen versus control. So after that evidence from WHI, there were a couple of other randomized blinded studies that looked at that looked at basically using early estrogen. Two of the studies, KEEPS and ELITE trial, both of them suggested cardiovascular safety of hormone therapy initiated early in menopause based on favorable cardiovascular biomarkers. So both the studies after WHI, it was hard to recruit a lot of patients into these type of studies. So it was underpowered to assess primary cardiovascular outcomes like heart attacks and stuff, but they looked at different biomarkers like carotid intimal thickness and calcium scores and things like that, and then showed there was a favorable effect if you took the hormones early. So when do you not give it? Well, what are the contraindications? So if you have existing estrogen-sensitive cancer, don't give it. If you have unexplained vaginal bleeding, please assess that, and then make sure it's not cancer, treat it, and then you can do hormone therapy. If you have a triple negative breast cancer, then you can consider giving the hormone therapy if they've been treated for more than treated and considered treated for 5 years from diagnosis. So triple negative breast cancer, before we used to not give any breast cancers hormone therapy, but at this time, there is some room for hormone therapy in a triple negative breast cancer as long as they've been treated for a while. You have existing coronary artery disease, stroke, or MI, that would be a contraindication. If you have a history of VTE or an inherited high risk of VTE, then that would be a contraindication. Active liver disease is also a contraindication for hormone therapy. And then for prometrium, which is a particular progesterone we often use, you would not use that if there was a peanut allergy, but you can still use other progestins or other estrogen, but I included that just because that is a common progesterone we use. Okay, so then I know just this slide, I know this was not part of it, but I just want to make sure I include, just for completeness sake, for non-hormonal options, we have options only for certain symptoms, like for vasomotor symptoms, libido, hair loss, and bones is where we have options for treatment. If they have all these other constellation of symptoms that menopause presents, we don't really have non-hormonal options for those. So just want to make sure when you are counseling the patients, you kind of consider that. So for vasomotor symptoms, you have SSRIs and physiolanitant, which is a newer medication that's FDA approved for vasomotor symptoms. And then for SSRIs, the paroxetine salt that is approved for that. And then there's also SNRIs, gabapentin, oxybutynin, that can be used for vasomotor functions, but it would be off-label use. And for libido, this is for perimenopause women, you can use phenylbutyrene and bremelanotide. Both of them have come in with their own little side effects and issues, but they can cause some moderate increase in libido. And then hair loss, of course, you want to make sure you're doing the workup for hair loss and exclude deficiencies, etc. But there are medications for that. And then for bones as well, bisphosphonate and parathyroid hormone can be given. So those are all the different non-hormonal options, but again, not for all constellation of symptoms that perimenopause and menopause presents with, but if these are kind of the main symptoms, you can use other medications. Okay, so then I'm just going to go ahead and talk a little bit more about oral versus transdermal estrogen therapy, because they are different and they can have different risk factors. So for oral, historically, that's what we used in North America. It does go through the GI tract, so it's subject to the first pass effect, which can then increase a favorable increase, which can increase the HDL cholesterol, but then it can also increase your triglycerides. It can increase your coagulation factors, upregulate some inflammatory factors, can also increase your sex hormone binding globulin. So it has some good effects, but some not so great effects because of the first pass metabolism. And then the transdermal, on the other hand, since it doesn't go through the liver, it is associated first with more stable serum levels, and it has minimal effects on the sex hormone binding globulin, so which then has less negative effect on sexual functioning because it won't bind up the free testosterone as much. So you'll have less effect on sexual functioning. It's basically it has some risk of transfer if you're using gel or creams to other people. If they're, again, in terms of just skin to skin transfer, they are available in different formulations like patch, spray, gel, etc. And then because because it doesn't go through the first pass hepatic metabolism, there are many studies that show that there is increased VTE and stroke risk with oral estrogen, but not with transdermal. So a lot of times when after adequate counseling and looking at their actual risk of VTE, for people who have, say, a provoked VTE, may be still candidates for transdermal estrogen. So you want to take that by individual, but the risk of ETE is different for oral versus transdermal. And then we want to talk about the differences between systemic versus vaginal therapy. Systemic therapy, remember, it can be oral or transdermal, as we just talked about in the previous slide. We still need progesterone for endometrial protection. I think that's the third time I've said it, but you want to just make sure. And then the progesterone can be micronized progesterone, like I talked about that Prometrium, the brand, or any progestin, which are synthetic progesterones. The micronized progesterone is the only bioidentical progesterone available. And then the progestins are the synthetic. Or you can use endometrial protection by using a levonorgestrel IUD. But you want to consider the risk of VTE, especially with the oral therapy of estrogen. For vaginal therapy, which is mainly used for genital urinary syndrome of menopause, there are many different formulations available, like cream, tablet, suppositories, rings. Though I must say, one of the rings called FemRing is a systemic estrogen therapy that is inserted in the vagina. So you want to make sure if you're using that ring, consider that as a systemic therapy. But otherwise, all these other options are not really systemically absorbed. When they've done system serum levels, they're very minimal serum levels. So in this situation, you do not need endometrial protection. There are other options for vaginal therapy, including DHEAS and a SERM estrogen, like a selective estrogen receptor modulator, like ospemifene, that also will help with vaginal therapy. So for people who really cannot take any estrogens at all, these are the options. And then, a lot of the questions come to us from patients and some providers is bioidentical hormones versus compounded hormones. People often use these two terms as the same term, but bioidentical hormones are chemically identical hormones that are produced by our own body. So, so they can be estrone that's made by our fat with the aromatase enzyme, estradiol that's made by our ovary, estriol that's made mostly in the placenta when you're pregnant, and there's progesterone, testosterone, DHA, cortisol. Those are like our bioidentical hormones. But though bioidentical is a marketing term, it's not really recognized by FDA. So it's often used by the compounding pharmacy as somehow being, natural or safer. The bioidentical hormones can be made from biological sources. They can be made in a lab, they can be synthetic, but the molecule needs to be the same. Overall, the Menopause Society and ACOG have released position statements that against use of compounded bioidentical hormones, and do not endorse serum, saliva, or urine hormone testing to determine dosing. Because this is because they're FDA-approved effective bioidentical hormones that are monitored and regulated for purity and safety. So usually we do not recommend the compounded bioidentical hormones because there's some cons. They're not regulated. They don't have proof of claim, are not held to the same standard of manufacture. In fact, the Menopause Society did some studies about getting compounded hormones from various places at various times, and the dosing differences were so high in each of the different products, so they didn't think this was safe. So that's one of the reasons why they came up with the position statement. And then also there may be some harms associated with it, because especially with the pellet injections, where the pharmacokinetics is unknown. Their levels of hormones vary dramatically, and we don't know how long they last for. So there's lack of monitoring of adverse events with these type of compounded hormones, and then also often they're not covered by third-party payers. Now, there are some benefits, though. It does help with combining different drugs in some specific situations. There are various modes of administration as long as you know the absorption is correct. For example, progesterone creams are not well absorbed through the skin, so they may not provide enough endometrial protection. So, and then often you find in compounded hormones that the progesterone is given as a cream, so you don't want to do that. So, but there are some freedom of how things can be given as long as you know the absorption rates for those things. And then it's beneficial for people who do have allergies or intolerance to FDA-approved therapy, and then, because these can be prepared without binders or fillers or dyes, etc. So there's some benefit in women who need it in certain situations, but this should not be the go-to. Take-home points really need progesterone if you have a uterus and you're using systemic estrogen, and then avoid compounded hormones unless you have allergies or intolerance to FDA-approved products, or if there's no FDA-approved products and you really need dosing for women, then definitely great to use compounded hormones. For example, if you want to use testosterone for libido, which is off-label use, by the way, then you may want to compound the male testosterone down to the female level. So that can be done. And then vaginal estrogen, because it's not systemically absorbed, it can pretty much be used for almost everyone. So those are my take-home points. I'll be ready for questions, but I know we have question time separately, so we can do it at that time.